My name is Miguel Quiñones. I'm the professor of medicine at Weill Cornell Medical College in New York and chair of cardiology at the University of in Houston. I'm also the chair for the ACC 2013. We're definitely planning and hoping that many of you will be there with us in San Francisco, doing a similar wrap-up and making all of these great questions that you do for us. We're also very excited about this relation we started this year with the Journal of the American Medical Association, and we have Dr. Howard Buckner, editor-in-chief of the journal, with us today, and he's going to take over and run the show. I sit and watch. So, Howard?
Thank you. So, just some quick ground rules. First and foremost, if people want to chat with us, please call me Howard. Occasionally people address me as Dr. Bachner, and I've always insisted only my children have to call me Dr. Bachner. We're going to talk about 4 trials, ASSERT, RAMCOT-2, immediate, and MOLDED. So I just want to comment by saying I don't think any group of specialists has raised naming trials to an art form more than my cardiology colleagues. They have done an extraordinary job in creating trials. They almost take on a personality of their own. So just quickly on the ground rules, each presenter is going to be given about 5 minutes. We're going to hold questions to the end. And there are a number of members from the panel discussion in the front row who also may comment at the end. So I'm just going to introduce each person. They're going to make some comments. But I do really want to thank ACC. I think the real question is what's the role in journals at these meetings? And I think what we've seen over the last 5 to 8 years at this meeting and some others is this remarkable relationship and interaction between investigators, late breakers, online publication at the same time that articles and research is being presented. And the effectiveness of reaching clinicians, practitioners, and policymakers is extraordinary. So I would only point out, we last year at JAMA, our author report videos, not podcasts, averaged 20 million viewers a week. And so the ability to reach the public through new media is simply extraordinary. And I just want to point out over the last couple months, we've added new technologies to make access even easier at JAMA. So we've been experimenting with QR codes and some other new technologies. So I think part of the role of journals at these meetings is to really educate people who are interested in the information from these meetings. First speaker is Dr. Weintraub. You heard his presentation, classic CER study. Dr. Weintraub.
Thank you. It's really a pleasure to speak to you all recording class. I'm here.
There are cams in the back, picture taking, video cameras. You can't stand here. Okay.
Thank you. It's really a pleasure to speak with you all this morning about the ASSERT study. ASSERT is a major collaboration of the American College of Cardiology Foundation and the Society of Thoracic Surgeons. I, in particular, want to thank the other PI of ASSERT, Dr. Frederick Edwards, who's in the audience today. I'm glad to speak to all of you as well. ASSERT is, as Dr. Proctor said, a classic comparative effectiveness research study, and I think pushes forward the methods in comparative effectiveness research. We have indecision in many areas in clinical medicine, and it can be resolved by appropriately designed studies. In particular, here we're comparing coronary stenting with coronary bypass surgery. The bypass surgery being more invasive, stenting less invasive. There have been a number of randomized trials in this area. Randomized trials have the great benefit that they overcome treatment selection bias, but that's their only benefit. Other than that, there are all problems with randomized trials. They're expensive, they take long to conduct, they become outdated, and there's questions about generalizability. So observational studies have the benefit that they can be much larger and they're easier to mount and develop tremendous sample sizes and look at subgroups. So that was the reason for the genesis of ASSERT. We started out with some 2 million patients in the Center for Medicare and Medicaid Services database. We linked that database to the databases of the Society of Thoracic Surgeons and the American College of Cardiology. These are tremendous clinical databases. Total number of patients in these databases is now in excess of, well in excess of 15 million patients. These are clinical databases, not administrative databases. When we developed our final study sample, we had over 80,000 patients with coronary surgery and over 100,000 patients with coronary stenting that we could compare. We used very advanced statistical approaches to reduce treatment selection bias, that is, those things that drive people towards one form of therapy versus another. And you can't correct for things that you don't measure, and we looked at that very carefully. What did we find? We found that at 1 year, there was essentially no difference in survival between patients undergoing coronary stenting and patients undergoing coronary surgery. However, at 4 years, we found a relative risk reduction of about 20% with coronary surgery compared to coronary stenting. 20% relative, 4% absolute, from about a 20% mortality at 4 years with coronary stenting to 16% with coronary surgery. We also looked in a number of different subgroups, and that's one of the powers that we have in observational studies. We have enough patients to really look at subgroups of interest, such as patients with diabetes and people with more severe disease. And what was really quite striking in ASSERT is how consistent these data were across our subgroups. So the real issue is in ASSERT, its ability to apply this in practice relates to whether there's remaining treatment selection bias. And we looked at that quite carefully with a number of different statistical techniques. But at the end of the day, you can never be absolutely certain that you've removed all treatment selection bias. So how do we get at this, and how do we use it to certain decision making? ASSERT is by far the biggest and the most generalizable of the studies in this space. I think that we set a methodologic standard for comparative effectiveness research with observational studies, but also the collaboration between professional societies, which I really think is critical to looking at our outcomes. I think this moves the bar along. Perhaps will lead us to some rethinking about our approaches, which in recent years have moved more towards percutaneous coronary intervention and less towards surgery. But I don't think anyone would say, well, now with the results of ASSERT, we just completely changed the way we do things. Except for this, I think that ASSERT will maybe help us do things better and lead to better studies in the future. So with that, I'll stop, and thank you.
The next speaker is Dr. Hoffman. His question is different. So he tried to sort through whether a new technology changes how physicians make decisions and its impact on important patient outcome, in this case, length of stay. And it's clear as we create new diagnostic and therapeutic approaches, incorporating them into clinical decision making becomes the ultimate question about how they impact on patient outcomes.
Thank you. Good morning, everybody. So, I first and foremost want to thank my group of co-investigators and the 9 sites at the US where the study was conducted over the last 2 years. And the study's topic is really an important one because it looks at our ability to use new technology to address very, very big problems in our healthcare systems. And in this case, it is the large number of patients who present with chest pain to emergency departments. And as you know, emergency departments are overrun these days. The Mass General Hospital is about 90% of the time on red alert, meaning patients need to either can't be seen by doctors or they lie on the floors and don't have a bed. So that is one problem that's kind of a collateral to our study. But what we try to do is we have a new technology that allows nowadays within 1 second a scan to freeze the motion of your heart and to look at the extent of coronary artery disease in the coronaries that supply your heart. And that information is high, or has high information value for physicians in order to determine whether someone's chest pain is actually related to a heart attack, potentially. And so in this trial, we randomized patients to either getting this new technology very early on after they were seen or presented to the ED with what we call a standard evaluation. And the standard evaluation typically takes about 24 to 36 hours, involves some kind of provocative testing at the end of the hospitalization to rule out coronary artery disease. What we showed, I think, in the centers were chosen, so we didn't choose CT aficionados, so we wanted to make this as generalizable as possible. So those were centers who had a reasonable experience in CT, but were more likely to treat both strategies actually pretty equal. So, and after randomization, we followed the patients. The care was dictated by the local physicians. And what we showed is that the patients who received a CT early, not very unexpectedly, a lot of them actually don't have disease. And by doing a CT, a CAT scan, you can rule out disease very quickly and send them home. So there is a benefit. So that was about 50% of patients. And just a number that may be interesting for you, it took 8 hours in the CT arm to discharge 50% of all the patients in that arm. 8 hours. And it took 28 hours to discharge 50% until 50% of patients were discharged in the standard of care. So quickly sent home a lot of patients, and as we showed, very safely. This was confirmed actually by a trial that was presented yesterday who showed that the patients who do not have disease, they can be sent home safely. They don't have ACS, and that was known before, but and this was one of the assumptions that our trial was already based on. So we could show that, and we could show that there are more direct ED discharges, so patients do not need to be admitted to the hospital. Now, what we also showed is that there is more testing that is done when you get a cardiac CT, because CT is very sensitive to detect coronary artery disease. And so more testing in patients who have disease, less testing in patients who don't have disease. One reassuring fact that was at the end, there was a similar cost to the hospital and the patient eventually in both arms. So there were studies which also kind of motivated us to do this study that showed when you do a CAT scan, you detect more disease, you have increased costs to the healthcare system. So we showed that this is not the case in this setting, and I think that's very encouraging.
Thank you. It's interesting as we move from right to left, we're changing the focus of where the studies were done. So the first is after you were hospitalized, it was surgery versus PCI. The second is whether you're hospitalized, what happens in the emergency room. Now we're going to move to what happens in the field, in paramedics. And I'm really delighted to introduce a friend and colleague, Harry Selker from Boston. I think his study is going to revive interest in a therapy that I think people had thought was clearly not beneficial, and I think his results are going to revive interest in it: glucose, insulin, and potassium.
Thank you, Howard. This may be resuscitation research where we try to resuscitate an old therapy. First of all, I want to point out Joni Bishansky and Jim Udelson in this group here, who are key pieces of the Central Coordinating Center, and Joni can talk much better about running of all the EMS systems, which was crucial to the success of this trial. Jim has a huge amount of experience in looking at trials of this sort. The immediate trial, which stands for immediate myocardial and metabolic support in the emergency setting, or thereabouts, is taking on a therapy that had been discovered 50 years ago in experimental animals and tried in humans, but unsuccessfully. Basically, glucose, insulin, potassium, GIK, was seen in animals to stop infarction, preserve the myocardium when the coronary artery was blocked until it could be reopened. There was great hope that this would save lives in patients who were having heart attacks. And as you heard in the discussion, well over 20,000 patients have been in randomized trials before, where they're treated when they come to the hospital with a heart attack. And the question was, can we save lives that way? And the answer was, sadly, probably not. But when you go back to the experimental lab, what you see is that, in fact, you have to treat them very early. We know that most mortality from heart attacks, in fact, occurs in the first hour. So treating them at 6 hours with GIK is obviously about 5 hours later than we wanted. Unfortunately, that's difficult, but we nonetheless took it on by treating people with having paramedics make the decision whether or not they had a heart attack or whether they were likely to have it. Do they have acute coronary syndrome? And we gave them decision support, the predictive instruments to help them identify those patients. And these predictive instruments were printed on the EKG. And then, out in the field, they decided whether or not to treat them with GIK. It was a fully placebo-controlled randomized trial, so they didn't know what they were getting. And the drug was started in the community, IVs were started in the homes and treated on the way to the hospital. And it was continued for 12 hours when they got to the hospital. Just to give you a scale of it, it was in 13 cities, 36 EMS systems, 54,000 patients were screened and had ECGs. Of those, 52,000 couldn't be included because they didn't have ischemia, coronary disease, evidence on the ECG or the symptoms. And ultimately, 911 patients were randomized by the paramedics in the field and then treated. And there's 3 groups that I want to talk about that we analyzed. One was the intention to treat group, which is the most important in a clinical trial. Those people that you tried to treat everybody, what happened to them? Another group was those who present with ST elevation MI, or at least ST elevation in pre-hospital setting in their homes. And that's because that's the group that we suspect would have the most benefit, and that's the group that had been tested the most previously unsuccessfully. And then the third cohort we looked at were those patients who we did additional biological mechanism tests, looked at the size of their infarction, the pumping function of their heart, and free fatty acids, which we thought might predispose to cardiac arrest. I'll give you just a thumbnail of the results of those cohorts. First of all, for the ITT group, the intention to treat group, the first outcome we looked at was whether or not people progressed to have a heart attack. And in that, there was no significant difference. And ultimately, we came to realize that it's probable that GIK does not change the coronary arteries, and that might not have been expected, as you heard in the discussion. However, what we also found in the biological cohort was that the infarct was much smaller. So in the placebo group, it was 10% of the left ventricular mass versus 2% in those who got GIK. 30-day mortality was 6% versus 4%, so favored GIK, but not statistically significant. Cardiac arrest and mortality together was significantly different. We went from 9% down to 4%, and that was significant. That's about a 50% reduction in the odds ratio for having those outcomes. For those who had ST elevation, again, infarction was not stopped, but the infarct was much smaller. In fact, people who didn't get GIK, the infarct was 12% of the left ventricular mass, reduced to 3% of those who got GIK. The composite of cardiac arrest and mortality was also significantly decreased in the people with ST elevation and MI. It went from 14% in those who got placebo to 6% of those who got GIK, and that was significant. We also looked at left ventricular ejection fraction, the pumping of the heart, and there wasn't a significant difference in that. We also looked, as I mentioned, at free fatty acids, which we know are related to cardiac arrest, and as I already mentioned, there was an effect of cardiac arrest. Those, in fact, were reduced by about 1/3 of those people who had GIK. So, we conclude from all this a couple things. One, the way to use GIK in patients of this sort is in the field in very early hour to acute coronary syndrome, and it can be done successfully in the field. And we think that model is useful not only for GIK but perhaps for other interventions. Also, we find that GIK, although it doesn't prevent heart attacks, it does seem to mitigate the size of them, and it does seem to prevent cardiac arrest and mortality as a composite. We are now looking at 1 year mortality and heart failure, and we look forward to reporting that in the future.
Thanks, Harry. For the last presentation, we're going to return to a hospital-based question, which is in adults with pulmonary embolism. Can we do a better job figuring out the appropriate dose of anticoagulation therapy? Dr. Sharifi is going to present, and it's another randomized clinical trial.
Thank you and good morning. MUPPET stands for moderate pulmonary embolism treated with thrombolysis. Pulmonary embolism is a lethal disease. Every day that passes in the United States alone, approximately 300 people die. And the majority of these patients' mortalities can be prevented. Now, the use of thrombolysis in PE is nothing new. It has been going on for many decades. And the dose that has been typically used in the US is TPA. It has been reserved for patients who are very sick. They present to the ER with cardiogenic shock, and this constitutes approximately 5% of all comers. There is a reluctance between practitioners in the use of thrombolysis in people who have fairly large-sized PEs, but they are stable. If you ask your pulmonologist colleagues about the last time they used TPA for stable PE, it would probably be a very low number. And this is due to, rightfully so, the dreaded complications associated with the administration of full-dose TPA, which intracerebral hemorrhage constitutes approximately anywhere between 2 to 6%. Also, there is major bleeding anywhere between 6 to 20%. So you cannot blame the practitioners for not using TPA. We believe that there is a safer way in the application of TPA in patients who have PE and who are not severely unstable. They have symptoms, they have ongoing symptoms, their blood pressure is okay, but they have very large size PE on their CT angio. And these are the ones that in the long run into problems such as chronic pulmonary hypertension, right heart failure, and its associated sequelae. Now, the rationale behind our approach was that we know from our work with DVT that lungs are exquisitely sensitive to thrombolysis. And the reason behind that is that the lung is the only organ which receives the entire cardiac output. And it's the point of convergence of all of the venous circulation. This is different from when we were using TPA for the heart or for thromboembolic stroke. Because imagine all those molecules of TPA which are administered in the venous circulation, they have to pass the lungs, pass the capillaries, enter the arterial circulation, and for acute MI, only 5% of the cardiac output gets to the heart. For stroke, only 15% of the cardiac output gets to the brain, whereas the entire cardiac output goes to the lungs. So with that in mind, with that rationale in mind, we randomized 121 patients, 61 into the safe dose or safer dose thrombolysis group, and 60 patients into the standard group. The standard group received the standard anticoagulation, enoxaparin for the majority of cases and heparin for approximately 20%. And the dose was 80 units per kilogram for heparin, followed by 18 units per kilogram, and thereby adjusted with PTT. In the lytic group, however, in order to reduce the likelihood of bleeding, we also modified the parenteral anticoagulation dose such that nobody who received heparin as a bolus more than 6,000 units. And those who received enoxaparin did not get it as the first dose of over 80 milligrams subcutaneously. In other words, if somebody was 100 kilos, maximum dose of heparin was still 6,000 units. Now, we realized that with this approach, the risk of bleeding was zero. In both groups, it was zero. And this is not, this was nothing that this was not unanticipated because we also had reduced the dose of parenteral anticoagulation. And we had some endpoints for this trial. There were primary endpoints and secondary endpoints. The primary endpoint was development of pulmonary hypertension in the last follow-up, which was 28 months. Determination of pulmonary artery pressure was by echocardiographic means. We used PA systolic pressure, and it was a binary definition. If it was more than 40 millimeters of mercury, PASP was defined as presence of pulmonary hypertension. There was also the composite endpoint of pulmonary hypertension and recurrent pulmonary embolism at the last follow-up. The secondary endpoints were development of bleeding and duration of hospitalization. As far as primary endpoints are concerned, at 28 months of follow-up, only 16% of the thrombolytic group developed pulmonary hypertension versus 57% of the control group. The composite endpoints again was 16% in the thrombolytic group versus 63% in the control group. Also, what was interesting to us was the duration of hospitalization, that it could be reduced dramatically to the average 2.2 days in the lytic group versus 4.9 days in the control group. And that may have significant health impacts in the future where the administrators are trying to safely reduce the duration of hospitalization. We also believe that this dose of thrombolysis serves as a form of pulmonary stress test. Those who have infarction, they start to have chest pain, and we may have to keep them a little bit longer, versus those who do quite well, they're ambulatory, and you walk them, and in a matter of 1 day or two, they can go home. So the clinical implications is that the majority of patients with pulmonary embolism who are symptomatic can be safely treated, provided the practitioners use a modified dose of TPA and a lower dose of concomitant anticoagulation. It leads to early hospital discharge and a reduction in pulmonary hypertension in the long run. Thank you for your attention.
So we'll turn to questions. If people could just go to the microphone, and if you just don't mind identifying who the question's to, and I'd remind the respondents just try to keep their answers short so we can get a lot of questions in. First question.
This is Dr. Weintraub. Can you say how many PCI patients who are actually eligible for coverage?
So yeah, that's really an interesting question. It's not a variable that's in the NCDR database, and would actually require prospective data collection. So we don't know. The suspicion is the majority would be, because technically you can generally, if you do PCI, you generally do coverage, but not always. There are also patients that would be frail or otherwise have comorbidity that we would choose not to.
So would that affect the interpretation?
Potentially, yes, and that's why we look for the influence of an unmeasured confound.
Justine Gannett from cardiovascular business. Dr. Weintraub or whoever else would like to answer. For a CERT, how does this contextualize courage, or does it at all?
So courage was in a very different patient population. that they were patients with less severe coronary disease, where there was a randomized trial of 2,287 patients comparing outcomes of coronary stenting, at that time with bare metal stents, versus medical therapy. Well, we found no difference between the two arms in the primary outcome of death plus MI, although there was better control of angina with vascularization. Patients where the choice is between cardiac surgery and PCI would generally be patients with more severe coronary disease. So, is it all part of one big puzzle? Yes, but I think that the studies cannot be sort of put side by side.
My second question is this going to change practice in terms of the patient population you would choose for ARC therapy?
So, it remains to be seen whether it will change practice. Practice has shifted very much towards percutaneous intervention and away from surgery in recent years. This may change it back a little bit. I don't think it's going to have a tremendous effect by itself, probably shouldn't. As I've said in my remarks from the podium, I think what we really want to do is rethink to some extent and work with surgeons, interventional cardiologists, and our patients to try to do the best possible decisions.
Since you welcome many other comments, I'd like to add a couple of comments. I think it's a very important data that we're looking at. Right? I think as members of the press, it's very important you all understand the differences between randomized clinical trials and registries. Randomized clinical trials it's the best we can do in the clinical world to have a laboratory. It's not perfect either, but it's the best we can try to do to have an experimental setting trying to mimic a laboratory setting. They're smaller and they're very well controlled. The registry gives us the power of large number of patients, but have a lot of difficulties because you're dealing with data collected and observational type of information. So what the registry do for us, and this is a wonderful example, is gives us, they frequently point out to areas that are important to look at, that maybe we may not be thinking that clearly. Open questions that then makes us to go back and look. For example, here, it's going to open a lot of very interesting questions. Are there specific subgroups that may benefit? Is there a way that maybe cardiologists and surgeons should work together? Maybe some lesions are better targeted one way and others the other. So registries provide this wonderful opportunity to open this great number of questions. They don't necessarily give us a final answer. So the two balance each other, and they're just a very great tool that we have available to continue to move forward. So some of the questions you may ask may not be possible to answer because the registries frequently what they do is they open more questions than answers.
I'm Mike Crawford, I was one of the moderators of the session, and I just wanted to point out that in terms of is this going to change clinical practice, that whenever you look at surgery versus anything that's not surgery, you have to understand there's always an upfront mortality cost to surgery, because anytime you put somebody to sleep and invade their body, you're going to have a higher risk than if you're not doing that. So the key question is always when you look at these kind of survival curves, when do they cross? Because the surgical one early on always drops lower usually than the comparative treatment. But then there's a cross point if the surgery is going to turn out to be better where it crosses. In this particular study that Dr. Weintraub presented, it crossed at 1 year. And that's very early for this kind of research. Often they don't cross till 2 to 5 years out. So when you're talking to a patient about which therapy to have when they're candidates for both, you're telling the patient, well, if you survive the surgery, then you're going to live longer, down the road. But, your risk initially up front is higher. So some patients buy that and want to go for the long term. Other patients, it's a tough sell. So it's hard to say how this kind of data is going to impact patient care, because a lot of it's how the patient perceives the risks and their outlook in terms of long term.
I just want to say in that regard that Dr. Crawford brings up a very important point about patient preference. And it's really critical for us in making these decisions to listen to our patients and understand their preferences.
Mitchell's Own Cardiology News. A few questions for Dr. Sharifi. When you talk about a moderate thrombus, is that purely defined by size, or are there physiological parameters that are also identifying the eligible patients?
Yes, it wasn't moderate thrombus, it was moderate PE, and that constitutes a number of variables. One is the size, and B wasn't shown, but at least 2 lobar segments have to have been involved in order to qualify for this. And also, that's one part of the equation. The other constituents were presence of symptoms. This was driven by symptoms, presence of chest pain, in addition to any of the parameters which were described, tachycardia, tachypnea, oxygen desaturation, and also not necessarily seen in every patient, but they were evaluated for right heart function and size, if they were and also biomarker elevation. So they had to have clinical symptoms in addition to some form of imaging which shows involvement of at least 2 lobar arteries, but presence or absence of biomarkers was not a necessity. It was assessed, but it was not absolutely required.
Right, but I'm sorry if I wasn't clear. So, but when you talk about moderate, is the moderate referred only to the size, or is it also the symptoms and the other markers you were describing? Are those not at a more extreme level that perhaps would necessitate a more aggressive treatment?
To give you a simple answer, it's people who are stable hemodynamically, they have evidence of PE, and they have symptoms. So it had to be hemodynamic stability, had to be present. If that was present, it was defined as fine.
Also, you seem very confident in your assessment of the treatment being safe, and you had mentioned that one of the goals of this was to address the issue that physicians are often hesitant to use the full-dose TPA because of their concern about bleeding and intracranial hemorrhage. This was a very small study. How can you be so confident about having addressed the safety issue with this study?
Obviously, that has to be looked upon in larger studies as well. But we have a fair number of patients that we have a large number of patients that we're treating them for DVT. And our experience in the treatment of DVT with TPA, which is a low dose, we give them 1 milligram per hour, 24 hours. We're fairly comfortable with the amount of TPA that we believe can be given as a safe dose. Again, nothing is safe, but it's safer than the 100 milligram.
And finally, so again, given the modest size of the study, have these results led to a change in your local practice, and do you think this should be compelling enough to lead to change broadly in practice?
Well, it takes larger studies to come to a generalized conclusion in that respect. But in my practice, everybody who comes with a PE and they qualify for, they satisfy the conditions noted, we offer them the option of modified dose TPA.
Hi, I'm Michael Reardon from Heart.org. I have a question for Dr. Salker. I'm having a hard time, I guess, interpreting the message from this study. Given that the trial missed its primary endpoint, there seems to be a consensus, even among the panel members, that this validated the GIK hypothesis. I was wondering, what really is the message from this study? Was it did you choose the wrong endpoint? Is infarct size more important than actually what you looked at?
Well, it's understandable that would be confusing. There's really 2 ways that we're thinking, as I mentioned, that GIK would help. One is preserving, protecting the myocardium, and the other would be stopping arrhythmias. In preserving the myocardium, there's 2 things that might happen. One, you might prevent the infarct from actually occurring, or the other is you might mitigate its size. In retrospect, you're absolutely right. You think about it, GIK as metabolic support is unlikely to unblock the coronary artery. So the infarction probably already had started, was not prevented. However, as you heard, the size of the infarction was much smaller. So that suggests that the overall model then for myocardial protection is that It supports the myocardium when there's a lack of blood flow. There's less damage and ultimately less of an infarct for the heart. The other reason I think they were optimistic about the impact is because it was the mitigation not only of mortality but of cardiac arrest in the early hours in particular. And that's consistent with the experimental study. So I think, in a sense, you pick a primary endpoint that's important that you're powered to do, and in that particular case, progression to MI was not stopped. On the other hand, it does put together a whole bunch of outcomes which are all consistent in the same direction and consistent with the experimental model. So I think the reason for optimism is, in fact, after many years of negative trials that were treated later, now we see treating earlier, we see all the signals in the right direction. I think ultimately we need to do a larger study, but it's very encouraging compared to what we've seen before.
If you did a larger study, would you select infarct size as the primary endpoint, or what would be to validate this, what would be the primary endpoint of the study?
That's a really good question, and I can't, I think it's likely that we might just look at cardiac arrest and mortality, because the fact is, what we see as a signal is more than the halving of the risk ratio for that. If that were validated, I think the infarct size would be not as important, and it's also relatively expensive to assess. But that's really in the planning stages right now, so I can't tell you more than that.
I would like to also make a comment on that. I think this is really an impactful study. And one of the things is that this is not a very expensive treatment. But one important thing that we need to realize is that we are living now in an era that a lot of great things are being done for people with impending heart attacks or heart attacks. So we have reduced the mortality tremendously from the days that some of us were in medical school or internship. So it's harder and harder to continue to show benefit in the early times. And I think a trial like this, what's going to be most impacting is when a second trial shows the impact at a year or two. So that's when you start seeing those wonderful long-term effects of having an infarct size that has dropped by this much. It's harder and harder to do as studies now and in 30 days show dramatic impacts, because we are doing a lot of good things for this person.
Maybe just to add to that point, one of the things we've known, and you've heard it, years and years at these meetings, that mortality is in fact dropping very much from heart attacks in hospitals, but out of the hospitals where 3/4 of the deaths occurred, in fact, not so much. And so this is really an effect to go where the mortality is.
Hi, Crystal Brown with MedPage today. Another question for Dr. Sulker. Meanwhile, before one of those trials is done, before the 1-year mortality, the 1-year results come in, what should clinicians think? Is this just something that's interesting, or should they start thinking about trying it?
Yeah, that's a great question. GIK has been used for a long time in cardiac surgery, and it's actually also approved for use, but it hasn't had strong evidence yet to support its use in this setting at all. I think, as indicated, it's very safe and it's very inexpensive, and I think it would be up to the EMS systems to decide whether or not they want to use it. I still think it ought to be validated in a larger trial, but I think it would be inappropriate for it to be used in the EMS systems with proper assurance that they know how to identify the patients with their paramedics.
Ron Winslow, Wall Street Journal. Dr. Weintraub, is there any consideration, actually probably not a good database for it, but include medical therapy in this analysis, and would that be a valuable one for this patient population?
So it actually would be a very good question to address in this population. A very good question. The problem is I think the treatment selection bias in medical therapy in using non-randomized studies is yet greater than between two choices of vascularization. The CERT steering committee is considering this for a CERT 2, if you will, knowing that the difficulties in treatment selection bias and what we would have to do to assure ourselves that we could have meaningful results would be harder yet than we've seen.
One last question, more technical one. funding of this trial is stimulus funds. How is this funded, and how is it sort of connected to this comparative effect, this notion that's sort of been fueled with
So there are a number of grant cycles for comparative effectiveness. CERT was funded by our funding, so it's a stimulus go grant was a particular category. There are other funds, and increasingly funds available for comparative effectiveness that are coming out of a number of different federal agencies, including the National Institutes of Health.
This is a question for Dr. Hoffman. In the study, you showed that even though the CCTA screen group did have more treatment and more angiography, that they didn't cost more, but on the other hand, they didn't cost less either. So is there anything, and obviously this is, everything is very expensive, so is there anything going forward that you can mention as an idea to try to reduce costs, or any hope that you can maybe have fewer of these people who don't really have ACS coming to the hospital?
That's a really good question. I think we were given previous reports that saw actually a doubling of costs of the CT, really attributed to the increase of subsequent categorizations and bypass surgeries and stent placements. We were very happy to see that there was no increase in costs. I think that's a major step forward, and I think if you put this in perspective, one was a Medicare data analysis, and this was a randomized trial where we, for example, certified CT readers, so they had a certain common ground of quality of reading, which I think is really a very important attribute or very important component how CT will influence downstream testing. So I was not disappointed at all. I was really happy to see the costs being the same. But to your question, there's obviously room for improvement, and room for improvement is in improvement of people getting used to receiving, dealing with cardiac CT instead of its stress testing in those patients. Although we have made a lot of progress, still in this trial, for example, none of the emergency physicians routinely use CT before the trial to manage patients. And so for each of them, it's a big challenge. They know the theoretical background, so they know the accuracy and the outcome studies. They know, whether it's 92% safety or 99% for certain CT findings. And now what they have to do is they have to determine their own threshold, what they're comfortable with doing. So I think that is where we will make progress in the future. And obviously CT technology is evolving. We will further see an improvement in image quality, which also will decrease downstream testing. And we have seen on the example of nuclear stress testing that specifically here, the Medicare reimbursement rates have come down tremendously for imaging.
Let me just make a comment about cost. I agree with what Dr. Hoffman said, but you have to realize that his study was very contained. The test was only available Monday through Friday during business hours. So if you expand this to 24/7 coverage, the cost has to go up. And the question is, would you save downstream by avoiding other tests and stuff? So that really remains to be shown in the future.
So can you discuss the likelihood of getting another study done in this area? There's been this long string of negative studies with some of the skepticism in the community, and whether you think it's actually likely to actually be done.
I think the chances are much higher than they were a few years ago. I think that there's a lot of, my impression is a lot of interest in the trial. Obviously something that costs on the order of $50 a bag, they can save lives on that order. I think must say that obviously there's no patent for money to be made on GIK, so most trials of this sort would be done quickly if there was a molecule that could be sold, and that's not the case. This is a public interest issue, and that's what the NIH is really about, which is supporting the investigation of things that help the public's health, regardless of the profit motive. And so I'm proud that the NHLBI and the NIH supported us, and I hope we'll do that again.
Which is all radiology news. A question about a cert for Dr. Weintraub, perhaps if Dr. Fuentes or Dr. Crawford want to comment on this too. You made the comment a few minutes ago, Dr. Weintraub, that you would hope that these results would influence practice, maybe change it a little. And what I find hard to understand is looking at the findings that you reported and compare it to prior comparisons of PCI and CABG. Granted, in earlier eras, I don't really see that much of a difference of the main message that CABG does have a long-term mortality edge over PCI. So I appreciate that this is in a uniquely large database, and you did some statistical analyses that were new, but the overall finding that you reported, what is new about it that might add something different to what's already been appreciated?
Well, you sort of answered the question already, so I'll reiterate some of the points. It's larger than any previous study. It's contemporary data, so it's using contemporary methodology. That is technical methodology within cardiac surgery and cutaneous coronary intervention. It's more generalizable because it covers the whole country. The penetration of these databases is now tremendous. Dr. Edwards might want to comment as well, but the penetration of the SDS database is now well over 90%, and the CAP-PCI database over 80%. So this is representative of what's really happening. In addition, I think that we took the statistical methods to another level. And I think that the influence of the societies coming together to study outcomes and conduct a comparative effectiveness study of this magnitude. All that together, I think it's pretty influential. But all findings in areas where there's been a lot of study are incremental. We shouldn't look for some wholesale shift in the things that we do.
And one other thing, I recall from Syntax that one of the interesting findings was that although CABG had the mortality benefit, it did have a decrement, or it had a downside of increased levels of stroke, and we did not have stroke in the analysis. Were those data not available, or why did they not include a stroke assessment?
So, yeah, I might have planted that question, actually. Stay tuned. Composite, individual and composite endpoints are coming, and I expect we'll be presenting such results at the American Heart Association.
Hi, Sanenga from the Heart.org. I wonder if anybody on the panel, and perhaps Dr. Sharif or I've already asked him, could comment on his findings, given what we heard from Einstein yesterday, that you may be able to give oral results with lots of iconics or anything.
If I understand the question correctly, you want me to compare our results to the doctorate study from yesterday?
Dr. Sharifi.
Dr. Sharifi.
The Einstein trial that you mentioned, it's a whole anticoagulant. This is probably the first time that without parenteral anticoagulation, initial attack towards PE has been with the Magnolia regimen. But that remains to be validated in the future with larger scale trials. Our study was not defining that approach. It's just another way of getting rid of the clot parenterally sooner than getting the body to dissolve it, because the parenteral anticoagulation does not dissolve that clot. The body's intrinsic lytic system has to dissolve that, and that takes a few days to weeks and maybe months. And by that time, significant changes in the histology of the tissue has taken place. But attacking PE with an oral anticoagulant would probably revolutionize the field.
Is there anyone in that field that would feel confident using the same dose TPA that Dr. Sharif has described on the basis of this small trial, or would you be wanting for more data for the kinds of patient he has described?
I think right now the guidelines state that you only use thrombolytics in patients with hemodynamically unstable pulmonary emboli, the most severe cases. So to move back to cases that are hemodynamically stable but are symptomatic, which is this group that was studied, I think based on this pilot study, I don't think you're going to get a huge acceptance of that at this point, although I think it's very intriguing and provocative, and hopefully a bigger study will do.
And this is in keeping with the way we progress in medicine. Usually trials of this type makes us think about changing the paradigm and then stimulates for big trials. I agree entirely with medicine.
Last question.
Chris Kaiser with Next today. I have several questions for Dr. Hoffman. The training that you conducted for the readers and physicians and clinicians to operate the CT scanners, did you include that in the post analysis?
The question was whether we conducted an analysis of the quality?
No, of the cost.
Oh, the training, no, that was not included in the analysis. So the analysis of cost was done based on the medical records for each individual patient's on the billing records. It included the technical and professional costs, and it included costs that occur when a patient is admitted to an ED or to a hospital, one-time costs. So it's probably the most detailed way of being able to project or to document costs, but the training was not included.
Do you think that providing this type of training for a center that wanted to begin this strategy would how much would that cost? Would it hinder some of the centers from incorporating the strategy?
No, I don't think so. I think physicians are, before they are even able to do CT readings and get reimbursed for it, they have to be qualified, and for that they attend courses. Our readers were actually all qualified by just general standards, but we wanted to make sure that we have actually a knowledge of their, how good are they reading. And so I think, well, to answer the question directly, no, I don't think this will pose any problem with getting those readers. But I think a bigger question is whether the standard requirements for reading that are out there, whether they are actually sufficient for doing such a specific task of reading those patients in acute chest pain patients.
Okay, and the 13 patients that came back to the ED during the 28-day follow-up, were they patients that were initially missed on CT?
No, those were not patients that were missed. Those were patients that were treated appropriately, and then most of them medically, and they came back with chest pain, but did not have ACS. There was no missed ACS in the study.
Right, but wasn't that metric in the first 72 hours?
Yeah.
So I was, 28 days later, I was wondering if they came back and perhaps...
So over the next 28 days, there were 2 patients who had an adverse event in the CT arm and 5 in the standard of care arm. Most likely, those were among the patients that were hospitalized. That's correct.
What were the specific adverse events for those 2 patients? That was my next question.
The adverse events, I think one patient was an MI and another patient was emergent hospitalization.
So, was that something that the CT missed?
No.
Thank you.
I want to thank everyone. I really want to thank the ACC. And then lastly, you've heard quite a bit about comparative effectiveness research, and I'd like to just say in 2 weeks, our entire issue, we have a theme issue that's committed to comparative effectiveness research. And there'll be 5 research reports and 5 or 6 opinion pieces about the benefits and risks of CER. Thank you very much.
Thank you all for coming.